So, if you see a guy with heat intolerance and weight loss who looks like Igor from Young Frankenstein, you can be pretty sure it's Graves' disease, right? Sure you can. But what if the patient doesn't have exophthalmos? It could be a number of other things, and the most important alternate cause of hyperthyroidism that you need to know is the toxic thyroid adenoma. Unlike Graves' disease, which is diffusely enlarged on palpation, a thyroid adenoma can often be felt as a palpable lump on the thyroid. And as we mentioned, thyroid adenomas are never associated with exophthalmos or pretibial edema, whereas Graves' disease often is. Finally, the thyroid gland is often assessed by the level of radioactive iodine uptake, a method called thyroid scintigraphy. While Graves' disease will show diffusely increased uptake, a toxic thyroid adenoma will show up as a focal increase in uptake, colloquially known as a hot nodule. If there are multiple focal adenomas, then you call that a toxic multinodular goiter. Now, radioactive iodine scanning is kind of awesome because it's useful for other stuff as well. For example, what if the patient had all the symptoms of hyperthyroidism, but his thyroid had pretty much no uptake? Now, one likely explanation is that he's actually in the early stages of either Hashimoto's or subacute thyroiditis. Remember, at that point, they will be releasing all their stored thyroid hormone, but the inflamed thyroid's too sick to suck up iodine and synthesize more. Another reason is that they're taking exogenous thyroid hormone. Either they're accidentally taking too high a dose of levothyroxine for their hypothyroidism, or they're abusing thyroid hormone to lose weight. Both of these will feedback suppress the thyroid gland to diminish endogenous production while causing the symptoms of hyperthyroidism. But on another note, what can a thyroid lump mean besides a reasonably harmless adenoma? You got it, cancer. As is often the case with endocrine tumors, though, the actually malignant cells are often so far mutated that they're not really very good at producing the hormone anymore. So, if you see a scan like this one, you can feel pretty good about that, because a hot nodule is a working nodule, and in the thyroid gland, that almost always means that it's not malignant. A cold nodule, one that doesn't take up the tracer, is a lot more worrisome. On that note, let's take a look at some of the thyroid cancers.
The most common type of thyroid cancer is papillary thyroid carcinoma, and is one of the few cancers where the histologic appearance is somewhat important. First of all, it's called papillary cancer, so what does that tell you about the histologic appearance? Papilla means nipple, so obviously it was named by a male pathologist who'd clearly never seen a nipple in his life. Here's what they're talking about. It's what I'd call a finger-like projection. On the same note, you'll hear the word psammoma bodies associated with papillary thyroid carcinoma. They're these cool bullseyes that look like the cross-section of an onion, and it's basically what happens when one of those nipple-like projections gets calcified, and you get a cross-section of it on your slide. Now, if that word sounds familiar, it might be because papillary thyroid cancer is just one of a handful of cancers that can have psammoma bodies visible on the slide. Do you remember the mnemonic for the others? It's SAM, or papillary thyroid cancer, serous cystadenoma or adenocarcinoma, meningioma, and mesothelioma. But the buzzword you'll hear most often with reference to papillary thyroid carcinoma is Little Orphan Annie eyes, which, in case you weren't born in the 1950s, looks like this. Apparently cartoonists in that era thought it was cute. I think she looks like she needs an exorcism. Anyway, you can see one of those eyes right at the tip of the papilla, where you'll note that the soulless emptiness in the center of the nucleus is actually quite reminiscent of Little Orphan Annie. Like I said, the histology is the most noteworthy part of papillary thyroid carcinoma. Fortunately, though, this cancer has an excellent prognosis, though if it spreads, it tends to do so via the lymphatics. There's a few gene mutations that are associated with the development of thyroid cancer, but you should note that this is one of the cancers that can be caused by ionizing radiation, especially when you're young. It's partly because of this that we try not to CT scan children unless we have to. Medullary thyroid carcinoma is the other one you have to know a little bit better than average. It's cancer of the parafollicular cells, and it secretes calcitonin. Possibly the most important thing about it is the association with the famous multiple endocrine neoplasias. We talk about them in their own session, I promise. Unfortunately, these ones have a poor prognosis, and actually, high-risk MEN patients often get their thyroids removed prophylactically. That's how risky it is. On a slide, you can see that unlike papillary carcinoma, it's got little chunks of nice shiny red amyloid floating around in it. Other than those two, the amount you have to know about the others is pretty minimal. First off is thyroid lymphoma, which is associated with Hashimoto's thyroiditis. There's follicular carcinoma, another one with a pretty good prognosis, which is unique because it's arranged into nice, neat follicles like regular thyroid tissue. None of this nipple nonsense going on. It's unique because it tends to spread hematogenously. And finally, there's anaplastic carcinoma of the thyroid, and does that sound like a good cancer or a bad cancer to you? Here's a hint. The word anaplastic is never a good thing in oncology. It means the cancer is so far mutated, it bears no resemblance to the original tissue. This one tends to happen in older patients, is locally invasive, and has a terrible prognosis. So surgery is the primary treatment modality for thyroid cancer, though radioiodine ablation is sometimes used to nuke the little microscopic chunklets that are left behind. But while thyroidectomy is a mainstay of treating thyroid pathology, there's a couple of very high-yield complications of this procedure. Can you think of any? The most obvious complication is hypothyroidism, which is sort of expected, right? Remove enough of the thyroid gland, and you ain't got no thyroid no more. Not too bad. You basically just supplement them with thyroid hormone after the surgery. The highest yield complications have to do with the nerves that you can potentially sever while ligating the arteries that supply the different poles of the thyroid. Remember what those nerves are? When ligating the blood supply of the thyroid, you have to watch out for the recurrent laryngeal nerves, which ascend from the thorax with the inferior thyroid arteries, that innervate most of the muscles of the larynx. You also got to watch out for the superior laryngeal nerves, which come from above with the superior thyroid arteries and provide innervation to the cricothyroid muscle only. Damage to the superior laryngeal nerve affects only the cricothyroid muscle, which tenses the vocal cords to allow higher pitched sounds, so damage can result in a low monotone voice. Damage to the recurrent laryngeal nerve is generally more severe. You'll end up with a very hoarse, weak voice, but since the most important function of the recurrent laryngeal nerve is to allow the vocal cords to open and close, you can get much more serious issues, like the inability to cough and increased aspiration risk. You'd have to be pretty unlucky to get both the recurrent laryngeal nerves cut, but if you did, that's bad news bears. Because in the event that the vocal cords get paralyzed while pressed up against each other, you've essentially just sealed off their airway with no way to open it back up. And if you're unable to get an endotracheal tube down there, you may very well have to cut their neck open to create your own airway. Let's see if you can figure out the final complication. What's another fun structure that sits directly on the thyroid itself? The parathyroids, of course. And what main electrolyte abnormality would parathyroid damage cause? If parathyroid hormone causes increased calcium at the expense of phosphate, then accidental removal of the parathyroids during a thyroid removal would cause decreased calcium and increased phosphate. And that's all I've got for you. If you liked the video, go ahead and give me a thumbs up down below. And as always, comments are more than welcome. Arjun Iyer, signing out. So we talked quite a bit about calcium regulation in the endocrine pathology section, and I'm not going to belabor that point here. But before I talk about the specific causes of hypo and hyperparathyroidism, I want to walk you through this beautiful graph I've adapted from First Aid and tell you exactly why I like it so much. This is a graph of parathyroid hormone versus serum calcium, and the normal physiologic range for both exists around here. Now, the reason I like this graph so much is that with all this positive feedback and negative feedback in endocrinology, it becomes kind of tricky to know what to expect. For example, if your calcium's too high, would you expect your parathyroid hormone to be running high or low? Well, you might say high because PTH causes calcium to increase, but that's kind of a chicken or the egg question, isn't it? Sure, if the PTH became elevated through, I don't know, an adenoma or something, it'll cause the calcium to go up too. But what'll happen to PTH if calcium goes up on its own? Remember, the parathyroid's job is to increase calcium if calcium isn't high enough. But if calcium goes through the roof, then the parathyroids basically just get feedback suppressed and go, well, guess you guys have it covered. And they leave for the Bahamas. You can also work this out vice versa, where you either decrease the PTH or the calcium, but it all really boils down to one simple principle. PTH increases calcium. So if the two are directly proportional, meaning that either both calcium and PTH are increased or both are decreased, it's pretty safe to say that the problem is primarily with the parathyroid itself. If parathyroid hormone became too high and caused the calcium to go up, we call that primary hyperparathyroidism. If the opposite is true, the parathyroid hormone drops leading to decreased calcium, we call that primary hypoparathyroidism. Conversely, if the two are inversely proportional, meaning that PTH goes up as calcium goes down, or vice versa, the problem is a PTH-independent calcium abnormality. The calcium's gone out of whack, and the PTH is appropriately trying to fix it, although failing miserably. Now, if I were in charge, which I'm not, I'd refer to these as primary hypercalcemia and primary hypocalcemia. As it turns out, in cases of chronic hypocalcemia, the parathyroids actually do get enlarged, and somebody thought that it'd be a fun idea to start calling it secondary hyperparathyroidism, because the parathyroids are getting big and secreting a lot of hormone secondary to disinhibition by hypocalcemia. I think that's a really stupid thing to call it, because there's no parathyroid dysfunction at all. The PTH is appropriately high to compensate for the hypocalcemia. But until I make some major discovery, I don't get to name doodly squat, so y'all just have to live with the name because it's all over the literature and textbooks by now. Now, you're probably still asking yourself, okay, but why do I have to know this? And the answer is because you'll be presented with this kind of information all the time on your test when it comes to calcium metabolism. You'll be given some clinical vignette that looks like this, and you'll be asked what the PTH value and the calcium value look like. Or you'll be given a set of labs that look like this, and you need to be able to identify what kind of pathology you're dealing with. In this case, with a low calcium and a low parathyroid hormone, what are we dealing with? They're both decreased, which tells you that it's a problem with the parathyroid, and since PTH is decreased, the problem is primary hypoparathyroidism. Not too bad, right? When it comes to endocrinology, these are problems you really have to work through yourself to become comfortable with. We're going to run through some scenarios right now, so take these seriously and pause the video if you have to think about them, because this is a lot like how questions on step 1 will be. First, if a patient's got a parathyroid adenoma, what are their lab values going to look like? So, the root of the problem is increased PTH, which causes increased calcium and decreased phosphate. Alright, that's a pretty easy one. How about this one? What if you have DiGeorge syndrome? Remember this one? It's basically a disorder of pharyngeal pouch dysgenesis, but the problem relevant to calcium homeostasis is aplasia of the parathyroid glands. So you have decreased PTH, hypocalcemia, and hyperphosphatemia. Finally, how about that one weird one? Multiple myeloma. Now, stop and think about this one for a second. Where's the problem really at? So, multiple myeloma is a very common type of lymphoma that's defined by invasion of multiple locations in the bone marrow. It causes all kinds of nastiness, including generating huge quantities of useless antibodies that gunk up your kidneys. But the part of this disease that's relevant to calcium homeostasis is that because it invades the bone marrow, it inevitably causes bone breakdown, and at later stages, it primarily causes the release of calcium and phosphate into the bloodstream. Now, if you use the diagram on the previous page, you'll guess the parathyroid hormone will decrease because of feedback suppression from calcium, which isn't wrong. But there's a bit of nuance here that you should be aware of from physiology. What's the effect of serum phosphate on parathyroid hormone? While increased calcium feedback suppresses phosphate, increased phosphate actually stimulates PTH to increase phosphate excretion for the kidneys. But because the ultimate purpose of PTH is actually to increase serum calcium, it's calcium that ends up being the major driver of PTH, and it does in fact follow this pattern. For bonus points, which ones of these disease processes will have elevated alkaline phosphatase? The answer to that one would have to be parathyroid adenoma and multiple myeloma. Alkaline phosphatase, contrary to popular belief, doesn't just increase during biliary obstruction. It increases whenever bone is being broken down or turned over as well. Finally, the last type of important high-yield question you'll see is a set of labs that you have to interpret. What disease do you think that this set of labs looks like? Okay, so let me make this a little easier. If you're trying to remember that graph I just wrote up in your head, you'll notice that while calcium is low, I didn't give you the parathyroid hormone. But there's enough information to make a diagnosis here. With low calcium, you're either dealing with primarily a weak parathyroid or an independently low calcium that's causing the PTH to increase to try to compensate. So the way you figure this out is you notice that the ALK phos is high, telling you that there's bone resorption taking place. Now, which process does that sound more like? primary hypoparathyroidism or hypocalcemia that's causing the parathyroid hormone to increase by comparison? The answer is the latter. In secondary hyperparathyroidism, the calcium is independently low, so the parathyroids try to increase the serum calcium by destroying bone, which raises the alkaline phosphatase. You can even get a little bit more specific than that. When you see that decreased active vitamin D is present, you can be pretty confident that you're likely dealing with secondary hyperparathyroidism due to chronic kidney disease. The reason is the kidney is the one that's responsible for the final hydroxylation of vitamin D. And this actually ends up being the most common cause of secondary hyperparathyroidism, so this is a good one to remember. Alright, well done on those questions. These are definitely some of the most challenging questions you'll see, but also some of the most important ones to practice. Like math, you only really get good at these after doing them, so when you get a chance, try to tackle some practice questions on First Aid RX. True hypoparathyroidism occurs when the low PTH causes calcium to run low. Now, take a moment and try to think through the physiology. How does this happen? How does one lead to the other? So the parathyroids, the little glands sitting on the posterior surface of the thyroid gland, are normally responsible for increasing the amount of calcium in the blood. And they do that primarily by promoting the breakdown of hydroxyapatite in bone to calcium and phosphate. Now, phosphate's a dangerous thing to have in solution with calcium because the two can precipitate out pretty easily. But parathyroid hormone takes care of that by causing the kidneys to dump phosphate into the urine while preventing calcium from leaving. Finally, PTH also upregulates the activation of vitamin D by the kidney, which uses its own pathway to increase the body's total calcium, and hopefully prevent parathyroid hormone from just tearing it all off the bones. It stands to reason then that hypoparathyroidism will understandably cause a drop in serum calcium. So, what are some of the things that make a person hypoparathyroid? Well, the parathyroids can be surgically removed, and more often than not, this is accidental. The parathyroids can be removed or damaged during a thyroidectomy or a radical neck dissection for head and neck cancer. It's important to know in these patients that the hypoparathyroidism may actually just be transient. The glands can be destroyed via autoimmune disease, kind of like Hashimoto's disease. And finally, what's that one genetic syndrome that causes parathyroid dysgenesis? Has to do with the pharyngeal pouches? The answer is DiGeorge syndrome, the one that involves dysgenesis of the third and fourth pharyngeal pouches. Review question. Which other organ comes from those pouches? It's the thymus, and DiGeorge patients are also known for having thymic aplasia. Symptoms of hypoparathyroidism are pretty much just the symptoms of hypocalcemia, which has gone over a lot more in the renal section. But a couple ones I want to go over right now are the Chvostek sign and the Trousseau sign. Chvostek for the cheek, and Trousseau for the triceps. Both are basically signs of nerve hyperactivity when you're irritated. With the Chvostek sign, if you tap on the cheek, the hyperactive facial nerve will cause the facial muscles to twitch. With the Trousseau sign, a blood pressure cuff cutting off circulation of the forearm will cause the forearm muscles to fire, which ends up looking like a carpal spasm. To touch briefly on a couple of pretty low-yield disorders, pseudohypoparathyroidism is basically what you get when the PTH receptor doesn't work, specifically the GS-alpha subunit. Type 1A is a defect in the receptors of the renal tubules, which basically lets phosphate stay as long as it wants and allows calcium to leak out. Now, y'all are pretty much rock stars at this by now, so tell me, what does the calcium and parathyroid hormone profile look like? Because the calcium is allowed to leak out of the kidneys, you get hypocalcemic. And even though there's phosphate retention from the kidneys, the calcium is still the primary driver of parathyroid hormone, so the parathyroids attempt to ratchet up the hormone production to try to make up the excess calcium. As you might notice, pseudohypoparathyroidism occupies the same PTH calcium niche as secondary hyperparathyroidism, which is why I think it's ridiculous to call them secondary or pseudo anything. I mean, both of them are basically just what you get when you have hypocalcemia and an appropriate response by the parathyroids. I guess you can remember that the parathyroid hormone really is elevated, so it's secondary hyperparathyroidism. And pseudo means false, so pseudo-hypoparathyroidism, I guess, means that the parathyroid hormone isn't actually decreased. Shut up, it's the best I got. Just remember that both secondary hyperparathyroidism and pseudo-hypoparathyroidism are forms of pathologic hypocalcemia that drive an appropriate compensatory response in PTH. To make things even more confusing, The phenotype for the GS-alpha mutation varies based on whether the patient's gene is maternal or paternal. The maternal gene is characterized by the hypocalcemia, hyperphosphatemia, and elevated PTH. But here's the weird thing. The GS-alpha subunit on the renal PTH receptor is also used in other cells. And it's the effect on those other cells that lead to a very characteristic appearance called Albright's hereditary osteodystrophy. It's where the kids turn out short and fat, with these funny little hands with the shortened fourth and fifth fingers. Oh, and there's definitely some issues with developmental delay as well. Now here's where the nomenclature gets real stupid. Turns out, inheriting a defective paternal copy of the gene has pretty much no effect on the kidney's ability to respond to PTH, but it does cause the syndrome of Albright's hereditary osteodystrophy. So some scientists saw these short fat kids with the funny fingers and said, I bet these kids have pseudo-hypoparathyroidism, stroking their beards and patting each other on the backs. And then they found out that they didn't really have a calcium regulation problem, they were just funny-looking kids. So they call the syndrome, I shit you not, pseudo-hypoparathyroidism, as in, looks like it, but it's not really pseudo-hypoparathyroidism, which drives me absolutely bugshit, because pseudo-hypoparathyroidism is already code for not hypoparathyroidism, and now you've got a disease that's not pseudo-hypoparathyroidism. But the stupid naming aside, the inheritance of this weird genetic defect is kind of cool in a way. See, the disorder of calcium regulation involving renal PTH sensing is inherited from the maternal chromosome only. And what's the name for that kind of inheritance pattern? It's a form of genomic imprinting. The father's copy of the gene gets deactivated in the cells of the renal tubule, and only the mother's is used. But the father's copy clearly isn't deactivated everywhere, because an abnormal copy of either the maternal or paternal GS-alpha subunit will get you Albright's hereditary osteodystrophy. So what do you call the inheritance pattern of Albright's hereditary osteodystrophy? While the renal sensing of PTH is inherited by maternal inheritance and genomic imprinting, Albright's hereditary osteodystrophy is actually autosomal dominant, even though it's on the same gene. Pretty wild, huh? Anyway, I think I've seen the word pseudo enough to last me a lifetime. Let's regroup with a flash quiz. Your question is, in a patient with hypervitaminosis D, how do you expect the values of parathyroid hormone and calcium to change? Go ahead and pause the video if you need some time to think. So, this question requires two-step reasoning. The first is to understand that hypervitaminosis D doesn't affect parathyroid hormone directly. It affects calcium. Vitamin D increases serum calcium levels, and while overdoses of vitamin D are rare, they can theoretically lead to hypercalcemia. Since the problem is primarily with calcium, we know that parathyroid hormone is inversely proportional to calcium, so hypercalcemia means compensatory hypoparathyroidism. And that's it for this section. If you like what you saw, go ahead and click on that thumbs up button down below, and as always, comments are more than welcome. Don't forget to check out the related and equally important sections on hyperparathyroidism, diagnosing parathyroid disease, and calcium homeostasis to round out your knowledge on all things parathyroid.